Okay, good morning or good afternoon, depending on where you're dialing in from. This is Steve Sirheinrich with Curvo, and I've got Ben Perrinen with Curvo on the line as well. And we are excited that you're here and looking forward to sharing some with you about how to make the supply chain your competitive advantage. I think everyone on is in listen-only mode. If you have any questions at any time, don't hesitate to chat those. I think what you do for that, you should be able to see either a Q&A or just a chat option. Ben is going to be watching for that, and if you have any, please jump in with some questions. I'd love to hear them, love to get some dialogue going if you like. And you can chat those, and we can even probably take you off mute if you'd want to discuss. So just some additional housekeeping. I want to confirm, Ben, are you able to see my screen?
Yes, I am.
Okay, great. Okay, so I'm the co-founder at Curvo, one of them, and this is our first series of webinars that we're going to start doing. Today's topic, how to make the supply chain your competitive advantage, is a more strategic overview kind of a topic. The following webinars we'll be doing every 2 weeks will be category focused, and for each category, we'll share market insights, pricing trends, sourcing strategies. We'll even include a subject matter expert like Stan Mendenhall from Orthopedic Network News, or Dr. Anshu Singh, who's a sports medicine surgeon and shoulder surgeon at Kaiser Permanente. And the idea behind those, whether it be endoscopy, total joints, spine, CRM, that's how we're going to focus the categories. It'll be to give you a lot of good insights, and they'll be really informative. We're also launching a supply chain leaders mastermind. If anybody's interested in that, you can join with me. The purpose of the mastermind is to bring people together to share ideas that may help elevate the supply chain in your organization. It's a low commitment, 1 or 2 1-hour meetings per quarter. And so if you're interested in that, contact me after the webinar too. We've got quite a few people interested. Now on with the webinar. How to make the supply chain your competitive advantage. Now, you've probably all heard the saying before, basement to the boardroom. So where would you rather work? Probably in the boardroom. It's such a great phrase because it's so true. 35 years ago or so, the supply chain was called purchasing, and they were in the basement, literally and figuratively. The job was to make sure that boxes got moved from one place to the other and on time. It was important, but it wasn't strategic. And still today, I've seen supply chains in the basement I've seen one in the basement of a parking garage, which floods when it rains. And I've also seen health systems spend millions of dollars to build a standalone, beautiful office space for their supply chain. So you can see now as it's changed quite a bit in that time, where supply chain is becoming much, much, much more strategic to the organization. And you can sometimes see that in where the supply chain is actually based out of, although that's not a criteria by any means. So I'm going to try something new here. I want to do a quick warm-up poll, and I'd like to see, of the people on this call, how would you rate your supply chain on a scale of 1 to 10 in terms of strategic value to your organization? So really it's how does the organization look at supply chain, and do you rate them? Do you think it's 10? Would they look at you as most strategic, or 1, very tactical, somewhere in between there? So if people you should see a poll on your screen, and you should just be able to click a button there and rate that. So I'd love to get your feedback. And Ben, if you're seeing anything come in, I don't actually see them.
Yeah, so we have, it's kind of all across the board. So the range is between 4 and 9. So
okay.
Looks like 25% or 29% are at 5, so that midpoint.
Okay, great. Well, this is good. So hopefully through this conversation today, you'll get some insights on how you can take back to the hospital as a whole, because this isn't just a supply chain issue. This is the whole hospital that you can take back and help add some more strategic value. Okay, so the point of this talk is to show you how to make the supply chain competitive advantage. And it's important because supply chain is the second largest spend category in the organization, I'm sure. It's very common for it to be. And there's data that shows by 2022, supplies will outnumber the labor costs in some hospitals. And so supply chain makes up, or supply spend makes up several categories. Today, we're really going to drill in on the implant and PPI spend because that's where I'm most familiar. These are the medical devices where GPOs typically have a weak value proposition. So you're probably doing local contracting around these. According to a Navigant analysis, there's a tremendous amount of savings to be had within supply chain, and they're estimating $9.9 million per year per hospital, which is going to be high for small hospitals and maybe low ones for big hospitals, but there's a huge amount of opportunity. Now, with implants and PPI, we do a calculation around that, and if you look at the whole average hospital supply spends $43 million. Within implants and PPI, you're looking around $15 million. And then I think it's reasonable to say that's 10 to 30% of that is available for savings in most hospitals, depending on where you are. So if you're curious on how I kind of come to these estimates, this is an example looking at just a regular hospital, any town, USA, net patient revenue. So we've got a formula here, and this is really actually very effective. It's back of the napkin, but you can start with net patient revenue, your own net patient revenue, estimate supply spend, use 12%, or if you know your exact supply spend, you can do that. And you can estimate PPI spend as 35% of supply spend, and then generally 10 to 30% of that is your opportunity for savings. So if a hospital has $1.3 million in savings, this is equivalent to essentially $26 million in revenue. And if you had 5%, that's if you had 5% operating margin. If you have less than that, 1% is equivalent to $130 million in revenue. So from a system perspective, if you need better operating margins, what's easier, getting more revenue, cutting headcount, or saving on supplies? And supplies seems to be the way to go. So the problem here is that if this is true, if this is really dollars going out the door, that actually equates, that 1.3 million equates to 108,000 per month. And so when you look at it that way, there's a lot of opportunity costs sitting within the organizations. And that's a lot of times displayed here in this example where you see savings opportunities. And so those savings opportunities range across those implant and PPI categories. A big chunk is in those big home run categories, and then there's a lot across the aggregate of many others. And so we sometimes look at these as opportunity costs. So the way we want to approach this problem right now is through the strategic sourcing strategy triangle. And this is something that we have taken from Pearlson and Saunders, a couple of PhDs who created the information system strategy triangle. And this is very similar, except we've made it for strategic sourcing strategy triangle for hospitals. And so on the top, you have the business strategy, and that's about aligning your healthcare system with your medical staff. And we'll get into all of these too. This is the key point of the talk today. The people strategy is about bringing clinicians into the supply chain. And the information strategy is about accessing the right information using technology to speed up your processes and be able to effectively share information and data with your leadership and surgeons. So let's jump into the business strategy. So alignment with physicians is critical. It's critical for taking costs out of care. It's the most important factor and thing to do. A lot of surgeons, supply chain team members, and C-suite leadership believe that their hospital cannot achieve best practices because of size. Well, I'm here to tell you that's not true. Data doesn't support that your size of your volume in many categories, it doesn't support that matters. What's really important is how you align with your medical staff, and that's a leadership issue. That's getting your leadership involved in that. I hear from some that the C-suite doesn't get involved, is afraid to talk with their surgeons to get them on board, and that's a shame, because that's number one most important. What you see here is business strategy is connected to people strategy through clinical integration, and people strategy is connected to information strategy with bandwidth, and business strategy and information strategy is visibility and measurement. So you're able to integrate with business strategy to people. You get that good clinical integration. You give information strategy, gives those people a lot more bandwidth, and then information strategy helps connect it back to the business strategy. So you've got visibility, able to share data, able to share information and measure results. So in the 80s, we had cost-based reimbursement, which meant if you wanted more revenue, you needed to incur more costs. Hospitals abdicated the supply chain to the GPOs, and this has led us to a lot of problems, in my opinion. Doctors became the customer, and the hospitals were stuck. Doctors became the customer to the medical device companies, and the hospitals were stuck paying the bills. So device companies, of course, are smart. They built a gigantic sales force to sell to the doctors, and people like to do business with people they like. So tight relationships form between surgeons and the medical device reps, and that's totally natural. But medical device companies are making a ton of money off of that. There's nothing wrong with them making money, of course, but the hospital should be profitable too. And here's top 10 US medical technology companies by revenue. You see Medtronic, 28 million. They've got a net margin of 12%. Stryker has a net margin of almost 15%. And so looking at hospitals' net margins, it just doesn't seem right. They are negative to 1 or 2%. So, but the doctors do need the device companies. So I'm not at all advocating that we remove them from the equation. In fact, I've got several slides from Bain and Company, and they're really interesting. It shows a lot of interesting data. And so number one thing that surgeons ranked is most important among the relationships with where they're getting their most information is sales reps. So critical for them to have that interaction still. Another really interesting slide and insight I got from this Bain and Company article was about physicians engaged in organizational decision-making and physicians not engaged in organizational decision-making. The Net Promoter Score, and that's basically saying do you like to work there, not like to work there, 47% to a negative 61 on the other, 61% on the other side. It's a drastic difference in the Net Promoter Score with surgeons that are engaged in decision-making and surgeons who are not. So it's a clear sign that we have got to get surgeons engaged in the decision-making. Additionally, what's interesting is 10 years ago, surgeons were the only relevant decision makers. Like I said before, they were the ones who decided, and the hospital had to go with it. And then 5 years ago, procurement really kind of took the lead there, and products were chosen on basis of financial and pricing data, and there was frequent conflicts with the surgeons. What looks like it's happening today, according to the Bain and Company study, is that pendulum has swung back, and that's a good thing. Surgeons and procurement are sharing authority over decisions, and surgeons are more sophisticated in multidisciplinary and multidimensional buying. So that's really great news. And so hopefully you can look at your own organization and see, hey, are surgeons involved in this stuff? If not, we've got to get them involved into these decisions, because not only do they need to be, they want to be a lot of times. Another interesting stat is that surgeons are saying they believe procurement has a neutral or positive impact on cost and quality. That's a good sign, because back in the day, they didn't have any regard for supply chain procurement there. So this is really good news. Surgeons and supply chain are working together closer and closer now. And this is another interesting fact. Percentage of physicians who agree or strongly agree with each statement. And this is comparing management-led and physician-led organizations. So the physician-led organizations have much more much more inspired by the mission. They believe there's the right structure and process and talent in place, and physicians and clinical staff are sufficiently engaged. Well, it makes sense if physicians are involved in the leadership for them to think that the vision's good and that the structure is right and that they're making good decisions, and that's important. So there's different ways we can approach the business strategy as a hospital. We can employ your physicians. It's kind of the lowest rung of engagement. I'm sure many of you on there have employed physicians and seen almost zero results from that. You could do co-management or joint ventures, or even bundled payments. Organizations that want to move toward value-based care will really need to include their physicians on these kind of things. And so those engagements like co-management, joint venture, bundle payment can really, really help. You don't necessarily have to offer your surgeons incentives, but it does help to get them engaged. Physicians want healthcare to work for the patient and the hospital. They also enjoy a seat at the table. Some ways you can do this is, like I said, employment, co-management, joint venture. But it seems like the bundled payment program may be the holy grail here. It really aligns the whole DRG to one cost, and overspend for medical devices is going to come out of the surgeon's pot as well. And the surgeon's going to feel that pain, especially if they're overpaying for the implant costs. So there's some things you can do to align that, and I know some of you on this call have done it before. Gain sharing program is something you can do. There's actually a Medicare shared savings program out there that I'm familiar with a few hospitals have done, and the surgeons can financially benefit from the cost savings. I know one hospital that did this shared savings program. They worked with their surgeons to get the costs dramatically lower. The surgeons agreed to, I believe, about a 90% market share to one device company, and this is in total joints, hips and knees. And in exchange, the hospital got a low aggressive price from the device company. So they're given a 90% market share, had to move a lot of business to that one vendor. And several surgeons, of course, had to change their practice because of that. But why did they do that? Well, each surgeon who performed this surgery with this particular device from this vendor earned $1,000 each time they implanted that device. And so that's a lot of money. I spoke with one of those surgeons, and he said that he didn't necessarily, it wasn't that the implant was better than the one he was using before, but the extra income he made through this program actually paid for a couple of years of college for his sons. And I think that's an interesting way to look at it. What does those savings dollars equate to? Something tangible and important like college. What would the surgeon or the surgeon group do with an extra $40,000 or maybe $4 million for the entire group? Would the individual buy a new Mercedes, or could they send the team members to additional training and seminars? Would a group of surgeons use the money for marketing to build their business? Maybe they would do that. And that would lead to more business, more revenue for the hospital and the surgeons. So that was that's just an interesting way, I think, to think about this. Now, I did read another study or an article from Modern Healthcare about a bundled payment program at Baptist Health in San Antonio. And a great quote from there was from one of the doctors. And it said, "The wonderful thing about this program is it put us all at the table together solving issues collaboratively." So again, very much the surgeons getting involved in this and being able to help with the decisions. They're feeling good about that. And in this case, the system actually brought their total joint implant devices cost down 29%, along with some other factors in there too, which is excellent for them. So that's a big savings. And I know you might think that, well, or you're hearing from your doctors that our implant costs can't go lower than this, or we get the best price, or we're not big enough in our community to get that better price. The device company rep has told them this, and it's challenging to get them on board. But there are things like the bundled payment program that you can leverage. There's gain sharing programs. There's that co-management and joint ventures you can leverage to get them on board. Not to mention, as we'll talk later, that people strategy and that information strategy to help get those surgeons on board and aligned. And finally, want to make sure that it's important and stress that the surgeons are going to look at clinical value as the number one decision point. But what's interesting, and this is comparing 2015 to 2017, is that economic value is now number third. And it shouldn't be first, because it's, surgeons are focused on the patient and the clinical outcomes, and so is everybody in the hospital. But it has passed in the last 2 years, this economic value piece, which is best value for price paid, has passed superior sales rep knowledge and support, and best education and training programs. So that's great. That's great news. It's seen right up there where it should be. All right, let's move on to the people strategy. As I mentioned before, the people strategy is about engaging clinicians in the supply chain. It's an important part because clinicians can translate between the surgeons and the supply chain teams. And that translator word, it's really key. It's a fairly new concept for supply chain to have clinicians involved, employed, and even have surgeons employed in supply chain. Back when supply chain was just focused on getting boxes here or there, it didn't matter much. But today we have titles like strategic sourcing and value analysis, and these are important titles, and you'll do your best work with a physician buy-in and having them on the team to help translate. We really need team members who can speak the clinical language. Without that, you can't get this clinical integration, and this goes both ways. It's having clinicians who can talk to the supply chain about the way the surgeon's perspective is, and it's also about clinicians who can speak dollars and cents and relate to the surgeons and the clinicians on that side. So I've met a lot of well-run organizations that employ RNs within their supply chain, and then there's some that actually have medical directors of supply chain, and we'll get into that in just a second. Without that stuff, this is how you may feel if you don't have the clinicians involved. Stretched pretty thin. And I know many of you will know as well people who have had really bad experiences trying to share some clinical information or share some data with the surgeon and had a really bad response back from. And that can get, if you've got team members on your team like that, they may be gun shy now to do things to share data with surgeons. And so it's just really important that we don't feel stretched. We have the people on the team to equip us. Dr. Gene Schneller from ASU, a professor of supply chain management, he says physicians should learn the language and drivers of supply chain. It's just as important for the physicians to understand how supply chain works as well as anybody else. So some things you can do. So first off, I've mentioned a couple times, RNs employed in supply chain. I see that happening a lot more nowadays. But you could also put physicians on product sourcing value analysis committees. I see that happen a lot as well. Another thing, though, is have your supply chain team members have dual reporting to the service line leadership. So they're reporting to their supply chain and they're reporting to the service line leadership, say the orthopedic service line or the cardiovascular service line administrator, where there's a P&L responsibility. Supply chain supporting or going through there in a kind of a matrixed organization could be really effective too. The other thing is supply chain team members serving interdisciplinary service line teams. Again, it's that integration to getting them and the clinicians integrated in conversations around costs and quality. This is an example from used with permission from University of Mississippi. I've always enjoyed, I like their org chart because they've got a chief supply officer, and then they've broken out purchasing as its own block there on the left, and strategic sourcing, which is connected by a dotted line to value analysis. And they have strategic sourcing and strategic sourcing value analysis teams there. So on this team, at the time I put this together, they had a director of strategic sourcing who was a RN, and they also had 4 managers of strategic sourcing, so 3 RNs and 1 non-clinical. And then they had value analysis steering committees and 8 teams around that. So some of you on the phone or on the call right now may look at this and go, well, we don't have enough people to do this. So you got to think about how can we wear different hats and where can we specialize at different times. The other concept is, and this is fairly new, is medical director supply chain. This is getting actual medical director to have either a full-time or part-time role within your supply chain. So I did a quick LinkedIn search here, and you can see that there's 7 people who came up in this LinkedIn search when I looked for medical director of supply chain. And it varies in different organizations, but we're seeing this more and more, and you can probably find them throughout. In fact, Dr. Schneller, who I just referenced in the quote before, he has a group that's does some research around physicians involved in supply chain. Then there's a few others. Dr. Chen from Baylor Scott and White, Dr. Chung from Providence, and Dr. Reiter from Sidney Kimmel Medical College and Thomas Jefferson University, Philadelphia. So they're very much involved in supply chain. One that I want to talk about is Dr. Tom Hazuki. So Dr. Tom's a really interesting guy. He actually is a neurosurgeon, and he was former VP of supply chain at St. Luke's in Idaho. So it's really unusual, I think, for a neurosurgeon to end up in supply chain. He was asked when he was at a previous employer to be the medical director, and it was going to be a part-time deal, and he was just going to do a few hours a month, and he was going to get paid at the same rate as his medical doctor rate was. And he was going to get involved and be that kind of translator, help him figure out. Made no commitments about it at the time. Didn't want to say he was going to be, going to get in this for very long. But you know what? Fell in love with it. It's really interesting. So it this is an example. It was a dyad model, and you could do this too, where it's strong administration and then Dr. Tom. The contract structure was performance expectations and annual review. Like I said, compensation was hourly. You could turn it off anytime, and a standard medical director agreement. So within a year, he had jumped to 30 hours a month and was involved in all 15 hospitals. He was working on the category level strategy, crafting presentations, meeting with individual physicians. There's an article you can look up about Dr. Tom, and they called him the translator. He later went on to, I think he fell in love with supply chain, got his MBA, and then became the VP of supply chain at St. Luke's. So it's a really interesting story and was very successful there. Another one, this is a good article if you want to look up from Healthcare Purchasing News, if you're interested in getting some perspective from surgeons who are involved in supply chain. Dr. Jimmy Chung, who's at Providence, he had a great quote. Having a physician leader in supply chain tells everyone that supply chain is serious about focusing on the patient and that it is ready to move into patient-centered, value-based healthcare universe. It also legitimizes the area of supply chain as truly part of practicing medicine for a population. I thought that was an interesting and good quote. So some encouragements there to you to figure out how you can get those surgeons involved in your supply chain. Another idea is category management. So the interdisciplinary teams and subject matter experts within your supply chain, let them focus on those categories, put their heads down and work on those and get those connections and relationships made so that they're really becoming the experts on those categories. And another, I think, really useful thing is think about your supply chain team, and do they understand not just the supply chain portion, but do they understand the jobs that are getting done at the hospital, and do they understand how the hospital gets paid? So one thing to do is actually have your supply chain team members job shadow other positions, job shadow into a surgery so they can see what it looks like when a total joint is implanted. Get them on the cath lab floor, the nursing floor, make sure they understand revenue cycle. I think this can all be really essential. There's the ARM organization, which is part of the Trade Association for Supply Chain, but there's also the HFMA, the Healthcare Financial Management Association. It doesn't talk a lot about supply chain, but it's a great place for your supply chain team members to also be plugged in, so they're learning about the finance side and the reimbursement side and the things that finance is discussing. I think that would really help the supply chain team members. And then I've just got one crazy concept that I want to throw out there. Is just this may be controversial. You may not even you may think, wow, this is great, I'd love to, and you may think this is completely crazy. But I'm curious if it would make sense to change how supply chain is compensated. I talk to a lot of supply chain team members, and sometimes I'll hear, it might be August or September, and they've already hit their savings goal, and they're not concerned anymore about hitting more, because there's no incentive there to do so. Hospitals will pay consultants to come in and run sourcing projects and pay them a shared savings. And they're, we've discussed before, willing to do gain sharing programs with surgeons and pay them to take costs out of care. So there might be some elements of this. This is definitely, kind of a sensitive area, I think. But there may be, if incentivized properly, you could get some really interesting and good results from your supply chain. Okay, let's move to the information strategy. And Ben, if you're seeing any questions come along, don't hesitate to jump in. All right, so the information strategy is my favorite. This is the last part. It's the glue that keeps the people and the business strategy together. It really makes the triangle. And I'm talking about data and technology to give your supply chain the bandwidth to do more work on more projects, because sourcing is very manual. The supply chain sourcing process is gathering data and it's about gathering data, identifying problems, managing projects, and tracking and monitoring that. And much of that may be not getting done because of the manual process and just taking up a lot of time. So having a good data strategy can really help you tell a story. That information strategy, good data strategy, can eliminate the bandwidth issue and the opportunity costs that are part of that process. So what I mean by having data tell a story is that with well-organized and accurate data, you can tell a story to the surgeon with the data, you can tell one to the CFO, and you can even tell one to your medical device reps, because data is power. All you're doing is presenting the data in a way that makes it understandable for them, and to kind of have them understand the story that you want them to understand. But it can be hard to get. So there's lack of transparency in the market. It's significantly limits the ability of a hospital to be prudent purchasers. Spend history and categorization is hard to clean up due to data entry errors and lack of controls. But physicians are not aware of the cost of devices they implant. In fact, according to a 2014 study, just 21% of the orthopedic physicians correctly estimated the cost of orthopedic devices. So what you can do is you can get access to really rich market intelligence. So this shows you here, this is biologic mesh. You can see what the relationship is between price and market share and price and volume, which is a very interesting point to look at, because your surgeons, a lot of times, like I said before, will be informed by their medical device reps about the costs or where they fit in, and if they can earn that lower price or not. But the data sometimes will really show that there's no relationship. It's inverse, actually, in some cases. It's just really weak between size and price. You can see if the trend in the market is going up or down. And so this is good information to be able to, if you have this at your fingertips, and that's what's important, is being able to get this data at your fingertips so you can then share it with your surgeons and help build consensus with them and get them to back you on and support your process. The other thing to be able to look at is reimbursement data. Supply chain needs to be aware of this and see what is the reimbursement level. A simple way to do this is look at your base operating payment for the DRG, and you can calculate out roughly 35% of that as the cost of the implant, if you want to make money on a on a Medicare reimbursed procedure. So this is good information. You have to have this data and insight to be able to share, again, with your surgeons and your leadership, and to help you make decisions and prioritize opportunities. Within like a total joint procedure or a spine procedure, it's really important to be able to have that construct level information available so you can see the differences between the practice patterns of your surgeons and be able to share that with them, to see the cost differentials between components with different device companies. There may be, most times the surgeons are not aware at all of the cost of the device, and so just by being able to share this can open their eyes. I know a story of my business partner, Andy, was formerly a director of materials management at a community hospital, and he pulled this data together, this is several years ago, pulled the data together to share with his orthopedic surgeons. In fact, actually researched to see what he thought the reps were making based off of the SG&A of the publicly traded device companies, what the reps were making per case. And sometimes the reps were making more than the surgeon was at that particular hospital. Presented all the information to the surgeon said, wow, I've never seen this before. And then surprisingly says, what do you want me to do? The surgeon was completely open to changing, to supporting, however Andy needed him to help within the organization. That's what he was willing to do because he had seen, was enlightened to the data. So luckily for them, they ran a sourcing project and a sourcing event, and didn't have to change the vendor even, but did get the cost driven way down because of that support. Tracking and monitoring, again, is really critical to be able to see within your spend where you're getting price increases, where you're getting that product creep. Many times you may work on a sourcing project and you have planned on a few $100,000 in savings, and 6 months from then, you aren't seeing that, or unable to report to the CFO who's asking, well, where are those, how's this showing up on my bottom line? And it's not clear because either the category has shifted with the vendors, perhaps you got some new surgeons in there and they shifted the product that caused a different market share between the vendors, and those products weren't actually sourced in that project. Or what a lot of times happens is the vendor will just upsell the surgeon to a more premium product then, so that to make up that lost revenue and that where that came from that great negotiations that you did. So being able to see that and not take much time to pull that information, especially to share with your leadership and your surgeon leadership and your administration leadership, but also when you do those quarterly reviews to be able to sit down with those reps and say, well, I know this product is priced at this in the market, and I'm seeing an increase in this utilization or not. Now, just having benchmarks and things like that is not enough to be able to, not enough of the information strategy. You really have to have all of the tracking and monitoring in a sourcing process. So some interesting study that I've seen about sharing data with surgeons. In December of 2016, a study appearing in the JAMA Surgery found that surgeons, given proper information and incentives, could reduce supply costs over time. The surgeons in the study who worked at an unidentified academic medical center were given a financial incentive to reduce costs by 5%. So one group was given scorecards detailing monthly costs, high-priced items used, and ranking of other surgeons' costs for the same procedures, while the other received no extra information. So over a 1-year period, they watched this, and the median supply costs for the scorecard group fell by 6.5%, while the median expense for the control group rose by 7.5%. So this trend remained even when the compensating for case mix index. Researchers identified 2 factors responsible for this positive result. So it was better awareness of supply costs and a willingness to emulate high-performing surgeon peers, sharing that peer-related data. So while surgeons in the study agreed that it was their responsibility to help reduce costs, those who used the scorecard system had a far better idea of how their performance items and their supply requests affected overall spending. As a result, this was much easier for them to adjust their supply choice accordingly and choose more cost-efficient items and devices. So really, really interesting to see that just by sharing that information. It's very clear. I mean, that's an 11% swing. A similar program was tested at University of California in San Diego in 2015. It didn't have any financial incentives, but it still provided surgeons with detailed amounts of their spending for each surgical procedure. So in some cases, there were product costs for items that surgeons never actually used, items that nurses had prepared in anticipation for the procedure but were unnecessary and represented an unnecessary expense. So with improved communication and more reliable cost data, the providers were able to cut spending on 18 of 34 procedures. So this represented total savings of more than $60K over a 4-month period. And in addition, feedback on the procedure time also helped surgeons better estimate their OR booking and utilization, improving their workflow. So a lot can come from sharing data and being able to share that data with your surgeons. So some practical things you can do, and then I'll wrap this up, was regularly share that peer costs comparative data with surgeons. You need to be able to have data at your fingertips. If you don't, you've got to look in how you're going to update your information strategy so you can be on a regular basis sharing that. Make sure you have annual savings goals too. I think most hospitals do. Occasionally I'll run into one that doesn't have a goal, and I think that's unusual, but make sure you have that annual savings goal and everybody's on board with that. All times really need to know the top 3 implant and PPI categories that you want to work on next. Have that calendar and that roadmap, but have it informed by what your savings potential is, as well as how easy or hard that category is going to be to work. So just because it's a huge savings opportunity, it doesn't mean it makes sense to work on that category right now. You might have 3 or 4 that are easier to work on because you've got better alignment with your surgeons and buy-in there in those categories. Not as much savings, but you can go knock that out rather quickly versus spending all your time on a large one that's going to be really complicated right now. And then think about, when was the most recent conversation with C-level about supply costs? It's critical C-level is involved. This is back to linking this business strategy back with the information strategy. The C-suite is hopefully making really good arrangements and deals with your medical leadership. And so you need to be able to give them that information back. They need to be checking in and aware of the supply costs and aware of the opportunities as much as possible. So to summarize this up in closing, I hope this gave you a few ideas to take back to your hospitals. It's very simple. The business strategy is about how we align with our surgeons, lots of different ways to do that. Incentives with money is one, but you don't always have to do that either. Just building that relationship, sharing information and data can help. Having the right people in the supply chain who have some clinical backgrounds. So even getting a medical director in there part-time, or doing those interdisciplinary teams so your staff can be part of the clinical conversations. And then having the information strategy that kind of keeps the glue there. And that's how you tell the stories with data. That's how you move through faster with your sourcing process. And so hospitals can use this triangle to kind of see where the gaps are. So hopefully you've maybe seen a few gaps that you might have. Some places you're probably doing really well. And if there are gaps, you can go back and plug those up. So I want to thank you all for joining the webinar. We did record this, so I can send it out. I also will send out a follow-up with some of these future webinars. I believe we're doing endoscopy category in 2 weeks, and that will have probably a half an hour, 25 minutes, half an hour, with a lot of really good data and insights to share. So if you have any questions about anything, don't hesitate to reach out to me. My email is steve@curvolabs.com. It was really fun to be able to present this with you. And I thank you all very much. Have a great day.